Good morning, everyone. On behalf of Niramaya Arthritis and Immunology Foundation, Jaipur, I welcome you all for this virtual rheumatology meeting in series of rheumatology clinical trials. Today's topic of discussion is polyarteritis nodosa, and we have two excellent speakers, Professor Ramnath Mishra sir and Professor Ashok Kumar sir. In first 1 hour, we will discuss 4 cases. I will present one case, and after that, I will ask both the speakers to answer the queries. So we will be able to finish these 4 cases in 1 hour time. And I request audience to send their questions in chat box so that after the presentation, in next 30 minutes, we can discuss all the queries. Professor Ramnath Mishra is Head Department of Clinical Immunology and Rheumatology, KIMS Bhubaneswar, former Professor and Head Department of Clinical Immunology and Rheumatology, and Dean at SGPGI Lucknow. He trained more than 70 DM students in Clinical Immunology and Rheumatology. He received APLAR Masters in 2021, Fellow of the Indian Academy of Medical Sciences 2019, SR Nayak Research Award by SGPGI MS 2017, MN Pasi Award by IRA 2013, Samantha Chandrasekhar Award by Odisha Vigyan Academy 2010, FRCP London 2009, ICMR Talent Search Fellow in 1979. He has more than 225 publications, total citations more than 8,000, H-index 44, and he was president of IRA also. Dr. Ashok Kumar sir, MD, FRCP, Clinical Director and Head, Department of Rheumatology at Fortis Hospital, New Delhi. He was Professor and Head, Rheumatology Services, AIMS, New Delhi from 1994 to 2009, recipient of All Oration of IRA 2001, President IRA 2007 to 2009, Editor IJR 2006 to 2009, recipient of Dr. MN Pasi Award of IRA for Lifetime Achievement 2016, Ahuja Bajaj Outstanding Clinician Award 2021, and he published more than 200 research papers. His area of special interest are spondyloarthritis, rheumatoid arthritis, and systemic vasculitis. With this small little introduction, I start discussion on PAN. The learning objectives are, in first case, we will discuss approach to vasculitic neuropathy. In second case, we will discuss tender nodules and non-healing ulcers. Then in next case, we will discuss peripheral gangrene and renal hypertension. And the last case is HBsAg associated polyarteritis nodosa. First case, young male, 20-year-old male. He had short history of 4 months duration. He presented with fever, malaise, arthralgias of large joints, pain in the shoulder joint, hip joint, and knee joint, fleeting pain, myalgias, significant weight loss of 9 kg in 4 months' time, severe burning, pain both hands and left foot, left index finger distal gangrene, and sudden onset wrist drop for 3 days. On examination, his BP was normal, left index finger gangrene was present, he had left wrist drop with asymmetrical sensory motor polyneuropathy, upper and lower limbs. His lab investigations showed high ESR, that was 85, CRP 121, anemia, neutrophilic leukocytosis, platelets of 7 lakhs. NCV showed polyneuritis multiplex, and his sural nerve and gastrocnemius muscle biopsy showed vasculitis medium vessels. His liver function test, renal function test, hepatitis B, hepatitis C, HIV, cryoglobulins, ANCA, ANA, APLA, and chest X-ray were normal. So to summarize this young male, presented with short history of 4 months duration. He had fever, arthralgias, myalgias, weight loss, digital gangrene, and mononeuritis multiplex. He had disc drop in form of mononeuritis multiplex, high acute phase reactants, and nerve biopsy was consistent with medium vessel vasculitis. So my first question is, when to suspect vasculitic neuropathy? Dr. Ashok sir.
Thank you, Dr. Banwari. So when somebody develops a sudden onset neuropathy of asymmetrical type, like, sudden onset of weakness, as in this case, left wrist drop, and may be associated with sensory symptoms as well. Well, often this is an axonal sensory motor type of neuropathy, and it may be in the form of widespread but asymmetrical involvement. Then you do suspect that this could be a vasculitic neuropathy, particularly if there are constitutional features as well, like in this patient, fever, weight loss. He also has some myalgias, joint pains. So all these do lead you to suspect vasculitic neuropathy. And here you also have digital gangrene. So there are very strong indicators clinically to say that he's got a vasculitic process. So one should proceed.
Dr. Mishra sir, would you like to add something? Sir, I think you are mute.
Right. As Professor Ashok told that he has giveaway features for a vasculitic neuropathy. So what we need is a neuropathic manifestation. He has had a recent onset sensory and motor neuropathy plus systemic features, and the fact that he has weight loss of 4 months duration, and high acute phase reactants and digital gangrene. So you have almost everything. Some patients would have new onset BP to be, diastolic BP to be elevated. But otherwise, I think we have nearly full house presentation to suggest that this neuropathic has an underlying systemic vasculitic process. And he has got high inflammatory markers as well, you said. So this is fairly, the diagnosis is almost written on the face of the patient.
Okay, sir. The next question is how to differentiate small vessel vasculitis, small vessel vasculitic neuropathy from medium vessel or polyarteritis nodosa. Dr. Mishra, sir.
As we know that polyarteritis nodosa involve the medium-sized muscular arteries. Small vessel vasculitis, as we see in ANCA-associated vasculitis, can also have a similar presentation of neuropathy with systemic features. There are certain points which do differentiate between the two. The important are involvement of eye, ENT manifestation like epistaxis, nasal blockage, and respiratory system, both upper and lower respiratory system manifestations, particularly hemoptysis, chest pain, And in the urinary system or the kidney, polyarteritis nodosa can have hypertension and some elevation of the creatinine. But the presence of frank hematuria points for a small vessel vasculitis. The cutaneous features can be similar. Both have an explosive onset of presentation. One thing is the hallmark of small vessel vasculitis is a relapsing remitting course, means the symptoms get better on treatment and they do relapse 50%. Perhaps polyarteritis nodosa does not have that kind of symptomatic relapse that we see in small vessel vasculitis. So, in summary, you have upper airways involvement, i.e., ENT symptoms, hemoptysis, the presence of hematuria, a rise in serum creatinine levels. Sometimes it can present as a rapidly progressive renal deterioration. These things differentiate small vessel from the medium-sized vessel involvement.
Thank you, sir. Dr. Ashok, sir, would you like to add something?
Well, I would like to only add that small vessel vasculitis can be not only ANCA-associated group, the other group is immune complex mediated group, where you have enoxacondyl purpura and urticarial vasculitis and things like that, cryoglobulinic vasculitis. They are typical examples of immune complex mediated small vessel vasculitis. And there, for instance, enoxacondyl purpura, you rarely get mononeuritis multiplex. You don't get it. Maybe one odd case report. Cryoglobulinic vasculitis you may get. So basically, the important fact is that classical PAN, when it causes neuropathy, it causes infarcts of the nerves because underlying disease is mostly medium vessel vasculitis. Even though the medium vessels involved in relation to the nerve are of smaller caliber compared to medium vessels that affect other organs, but still it is a medium vessel involvement and infarcts are there. The other ones, like ANCA-associated group, they may or may not have infarcts. They may have some other mechanisms of involvement of the nerve and causing disease there, and they tend to be, relapsing and remitting kind. So that's what I would like to add. But otherwise, I think the topic has been covered very well.
Sir, the next question is what are other differential diagnoses? But I think you have already discussed that other small vessel vasculitis like immune complex and ANCA vasculitis are the common differential diagnoses. Would you like?
There are other diseases also which cause a picture similar to this, like sarcoidosis, right? Even diabetes mellitus may have asymmetrical neuropathy. Vasculitis, you will come to know only after investigations, but and then there are viral infections, hepatitis B, C, HIV. They also cause a picture of asymmetrical neuropathy, mononeuritis multiplex. Things like leprosy, Lyme disease. There are differentials which go beyond the range of vasculitis as such. That can cause a similar picture, and one has to keep a broader differential diagnosis.
Dr. Mishra, sir, would you like to add something like how to differentiate vasculitic neuropathy from all these other features?
Well, as Professor Ashok said, that each of the other disease, suppose it's a systemic immune complex disease like SLE or rheumatoid arthritis, we could get clue from the other manifestation besides the gangrene and the the neuropathy that the patient has. And of course, diabetes is very common in our country. So, of the top of the investigation, one orders a blood sugar or a hemoglobin A1C. Rheumatoid arthritis patients usually have long-standing arthritis before they have vasculitic manifestations. So the diagnosis is evident from other disease. And these infections that was mentioned, HBsAg, HIV, and SCV, they all can cause they can cause the type of manifestation this patient has, but one need to get them excluded by investigation. Sometimes we also think of infective endocarditis because fever was there, and very rarely we have seen cases of mycotic aneurysms giving rise to embolization, and rarely manifest like this. So yes, basically vasculitic neuropathy, all the vasculitic neuropathy that we deal with, all secondary causes have to be ruled out. And most important, they say, is infection and metabolic conditions like diabetes and, well, sometimes malignancy. Infection, malignancy has to be ruled out to call it a primary vasculitis, as this case would represent. So, in fact, the list of differential diagnosis that an MD student is asked for the examination is quite elaborate. But in practice, we tend to exclude those conditions, as Professor Ashok told. The ANCA-associated vasculitis are very rare disease. Let me tell you that. More commoner conditions are immune complex mediated disease such as SLE, HBsAg, HIV, and SCV. And of course, I don't know whether any drug can mimic this, but infection and malignancy have to be excluded in order to ascribe it to a primary vasculitic condition. Because the treatment is very different.
Yes, sir. Thank you. Next question is, what are the classical histopathology findings of polyarteritis nodosa, and which is the best site for biopsy? Ashok, sir.
Well, the classical histopathology findings of PAN include, the infiltration of the wall of artery with inflammatory cells. So there is a transmural involvement along with fibrinoid necrosis, and the other feature they add is the loss of what is it called, the lamina between intima and media. Lamina propria, yeah. So that gets lost. So that is the typical histopathology leading to either thickening of the wall, stenosis, or its weakening causing aneurysm. And sometimes there is a clear thrombus formation on the intima. So those are the kind of histology findings that you get. So it's essentially the size of the vessel involved. So these are medium muscular arteries that are the main site of disease. And the lesions may be at variable stages of, progression.
Is it possible to get these classical findings on even skin nodule biopsies, sir?
Well, in the nodule also, if there is a medium-sized, deep dermal artery, you will get similar findings. So it can be, as a matter of fact, a good diagnostic material.
But it requires deep punch biopsy, deep.
Yes, not a superficial punch biopsy. You will need a scalpel biopsy. You will have to include the subcutaneous fat. So
Yeah.
those arteries are in the deep dermis.
And Dr. Mishra, sir, which is the best site for biopsy?
Well, the best site for biopsy is a sural nerve biopsy. And that too, if that sural nerve area is affected, there are advantages. If you do a biopsy, usually these nerve biopsy do result in some anesthesia or following the biopsy. But if the biopsied part is already affected, then we have little to add on to the patient symptom. It is said that when the patient has symptoms involving sensory symptoms involving the sural nerve, the pickup rate is very high, let's say 90% to 100% even. Of course, sometimes we don't find the classical changes. And one of the trick is identifying the sural nerve while biopsying. It's a fascia-like structure, and you need little experience in getting the nerve in the biopsy. The other sites, like testicular biopsy, if it is painful and swollen, and muscle biopsy have been recommended. But the sensitivity rate is somewhere in the range of 25 to 30%. I would recommend doing a sural nerve biopsy rather than this testicular or a muscle biopsy. If blind muscle biopsy, perhaps the pickup rate is low. And the problem with muscle biopsy, you have to go deep inside. And soon after that, you start with immunosuppressant treatment with fairly high dose of steroid. And we have seen cases who are left with ulcer, which has taken very long to heal.
Yes, sir.
I think sural nerve should be the answer.
Thank you, sir. And Dr. Mishra, sir, how to manage this patient? This is a now confirmed case of polyarteritis nodosa, vasculitic neuropathy. How to manage this patient?
Right. This patient would be categorized as moderate to severe disease because a vital organ, the nerve, is affected and a gangrene is there. In order to prevent progression of the gangrene or additional nerve being affected, one employs high dose of steroid, something like 1 milligram per kilogram body weight, but a max of 80 milligram. Even though patient is weighty, if his weight is more, you still limit yourself to 80. Usually we give 60 milligram of prednisolone and start with cyclophosphamide. There is no randomized trial or evidence, a randomized trial as evidence as to which is a good immunosuppressive drug. Cyclophosphamide is generally administered, borrowed from the experience we had from the small vessel vasculitis. So it's 15 milligram per kilogram of body weight. If the serum creatinine is normal, given every 2 weeks for the first 3 doses, and subsequently 3 doses are given at 3 weekly as a pulse dose. Some rheumatologists do also try oral cyclophosphamide. Oral cyclophosphamide in the dose of 2 to 3 milligram per kilogram. But personally, I find if you give oral cyclophosphamide, the cumulative dose in every month becomes little high for side effect. Though there are still people who use oral cyclophosphamide. So we are talking of 6 doses of cyclophosphamide pulse along with oral steroid. Now here is a catch. If you think that the patient you have seen is very recent, you could go in for a methylprednisolone bolus for first 3 days, 15 milligram per kilogram body weight, with which may be little, it can act fast and prevent any further deterioration. But I would tell you one thing, people who manage this kind of patient, the foot drop and did he have wrist drop? Yes. That is an axonal degeneration. It is unlikely to recover. When we give these drugs, sometimes there is, we have to counsel the patient, and one must be very cautious in saying that these things will improve. The digital gangrene, if the line of demarcation is marked, that is also gone. Means we have to assume that these two manifestations are probably not going to recover despite these kind of aggressive immunosuppression. 3 months down the lane, cyclophosphamide is changed over to azathioprine or to methotrexate. At 3 months' time, the prednisolone is down to 0.15 milligram per kilogram. So something like 7.5 to 10. And this dose is continued for 1.5 years. There are two things that does worry physician practicing here in India. One is the recurrence of during this immunosuppression, the occurrence of pneumonia, and also the fact that there might be a recrudescence of tuberculosis. But generally, I am not in favor of any prophylaxis such as cotrimoxazole and or ATT. The only that is how I would manage this patient.
Dr. Ashok, sir?
Well, Dr. Ramnath Mishra has very nicely outlined the principle of treatment, rather in quite good detail. I would basically like to emphasize the fact that, conditions like foot drop, wrist drop, gangrene, once they have happened, they are irreversible. Those things are done. Rarely you see foot drop recovering, wrist drop recovering. Majority of patients, they have lost this, function for good. Hardly 20% I would see recovering from such, neurological complication. So essentially, you are trying to prevent. And cyclophosphamide is not very quick drug to act. We give it with the hope that it will do a lot of good to the patient, but many times the pace of events is too fast. And what works is actually your steroid. Because in the first 2-3 months, cyclophosphamide has hardly kicked in.
Yeah.
So you are depending entirely on your steroid pulse, high dose steroid, continued treatment, ensuring that compliance is good. And with whatever is achieved in that period is the gain finally. And cyclophosphamide basically consolidates the treatment. And so when it is given for the first 6 months, it basically puts the disease into remission sort of. So that is the goal of, the entire protocol. Later on, you just maintain it for 1.5 to 2 years in the hope that the disease will not recur. And classical pan generally does not recur. Hardly about 15-20% patients will have a relapsing course. 80% will have a monophasic illness. Either this way or that way, the patient has his final outcome. So this is my viewpoint.
Thank you, sir. Thank you. Now we start second case. Young female, 30 years old female. She presented with painful tender nodules over legs with non-healing ulcers for 2 years. Mild constitutional features in form of fever, malaise, and fatigue. Often on fleeting polyarteritis and myalgias for 12 months. Her examination showed normal BP, healed nodules, and non-healing ulcers over both legs. ESR and CRP was high, and she had anemia. And her TLC, platelet, LFT, RFT, chest X-ray, ultrasound abdomen, echo, viral serology for hepatitis B, C, and HIV, negative. APLA, ANA, ANCA, normal. And before coming to me, she was treated with a high dose of steroids and methotrexate for 3 months. With that, she had partial response. This was her biopsy finding from the non-healing ulcer. So, young female, 30-year-old female, presented with tender nodules, non-healing ulcers, constitutional features, arthralgias, myalgias, raised acute phase reactants on this biopsy. What are the diagnostic possibilities? Dr. Ashok, sir.
So here we have a patient who has nodules followed by ulceration occurring recurrently and joint pains with raised acute phase reactants, and the biopsy already showing evidence of medium vessel vasculitis. So this is a typical case of cutaneous polyarteritis nodosa, as we call it, cutaneous pan. Already the disease is established for last 2 years. So very unlikely that this is going to become systemic disease. This is a cutaneous disease, skin limited. Already high dose steroid and methotrexate has been tried, and there has been only a partial response. Now, I know if it was not a young female, perhaps cyclophosphamide will achieve the goal that we are trying to. But here, after methotrexate, I would like to try things like azathioprine, mycophenolate mofetil, before deciding any other option. So one should give a try to the other alternative agents. If we fail, then we'll have to discuss with the patient as to what our options are. Blind use of biologic drugs like anti-TNF or rituximab or other things may be more like exploratory rather than evidence-based.
Dr. Mishra, sir, would you like to add on the diagnostic possibility?
No. The diagnosis is fairly evident. It's confirmed. As Professor Ashok Kumar said, that 2 years duration of nodules, non-healing ulcer, is a pain in the neck. You try many things. Each thing will act for 2 years or 1.5 years, and the patient will come back. He will survive. He will not have any survival issues, but it is going to be a painful ulcerative issue. The ulcers are very painful. They do respond to steroid. And sometimes I believe if you give an additional drug, it acts for a while. And then when all the drugs are stopped, again the ulcers come back, then they require steroid, and you don't like to put them on long-term steroid therapy. This is a classic example of a relapsing disease as opposed to PAN. PAN is not like this. This will not affect the kidneys, the heart, the lungs, but this will affect the skin in a very bad way, that the ulcers come back and come back and come back. One needs to theoretically exclude diabetes mellitus. There is a condition of paniculitis that can cause ulceration, erythema induratum, and of course, one can non-healing ulcer other condition in certain parts of our country. Sickle cell disease can need to be excluded. But by and large, I would think of cutaneous PAN.
Okay, sir. The next question, Dr. Mishra, sir. What should be the approach to confirm the diagnosis? In this patient, we have already gone for the ulcer biopsy, and this was the biopsy finding.
Yeah, you have in this particular case have attempted to do the biopsy and proven it. Many times when we try to do the biopsy, we only get necrotic tissues by the margin of the ulcers, and listen to the complaint that the ulcer boundary has slightly enlarged because of the biopsy. But I think biopsy is the only way to no vasculitis diagnosis can be made without a biopsy, and due care has to be taken for a skin biopsy. There is no blood test or anything else to confirm the diagnosis.
Dr. Ashok, sir?
Yeah, I think biopsy is the main method that we have. It is the histology that gives you the diagnosis.
Sir, the second thing is, can we have all these cutaneous PAN features in other vasculitis also, like in ANCA vasculitis or?
Yeah, but then you will have other features, multi-system disease.
Exactly.
You are talking of a localized problem which is confined to the skin. That is why the diagnosis of cutaneous PAN.
Yeah. The third question is, what are other features of cutaneous PAN? How it is different from systemic polyarteritis nodosa? Dr. Ashok, sir.
Well, basically, it is said that cutaneous PAN over a period of time may involve the adjoining, muscle, joint, and sometimes the nerve. So you may have development of a neuropathy in a cutaneous PAN in follow-up. But it doesn't go beyond that. So these are the features. So it will not have systemic features.
Yeah. And usually cutaneous PAN does not convert into systemic PAN?
Yes, that would be by and large true. Rare reports are known, but then those are exceptions. I would not give that impression to the audience.
Dr. Mishra, sir, how extensively we should investigate cutaneous PAN patient to look for extent of disease, particularly in early disease, like 3 months or 4 months history?
Nothing. Don't.
I'm talking about early disease.
There are three features. If they are present, fever, arthralgia, and I would like to emphasize that cutaneous PAN can have neuropathy. That is the only kind of extra vessel disease they can have. But if there is no history of weight loss or any other systemic features pertaining to other organ, we don't need to seriously look for extension of the disease. If clinical examination reveals something, then it's fine. Otherwise, there is no blood pressure, no chest X-ray is normal, and serum creatinine is normal. I don't think there is a appropriate basis to look for evidence of finding the pan in other systemic, other organs.
Excellent, sir. And Ashok, sir, when to investigate for DADA2 in these patients?
I think you have raised a very current interest question. Well, DADA2 is not that common a disease, but if you go by the description of published series from India, led by Dr. Aman Sharma, you should consider this possibility if a patient has CNS involvement, which here there is no clue, no such finding, or belongs to Agarwal Jain community, or there is a possible family history. Like I had seen long ago a lady from the Agarwal community only who had lost one, teenage son to polyarteritis nodosa, and he was brought dead to the emergency of AIMS. And 5 years down the line, she came with the second son, having suspicion that he also possibly has polyarteritis nodosa. That kind of scenario. Of course, at that time, I wasn't aware of DADA2. I'm talking of more than 20 years ago. But, if somebody comes across such a scenario, young patient and, family history, then such, autosomal recessive monogenic disorders should be considered. But in this patient, it's only arthralgia, ulcers, nothing more. That disease is actually more like PAN. It resembles PAN very closely, except that CNS involvement is very dominant. So I will leave it at that.
Absolutely, sir. And Dr. Mishra, sir, how to diagnose single organ PAN?
Oh, single organ PAN, you don't have a planned investigation. The most of the time that I have come across is when a biopsied appendix or a removed gallbladder showed evidence of PAN. There was, the patients have had appendix removed or the gallbladder removed, and the pathologist told us that it was the arteries, the medium-sized vessels were involved. So I don't really know whether you can plan an investigation to find a single organ disease. I mean, an intestinal organ or abdominal organ. It says that it is there in the testis can be involved, the appendix can be involved, and the gallbladder can be involved. I have had cases of appendix and gallbladder, but we never suspected a single organ PAN.
So it is basically histopathological diagnosis.
Yeah, it is.
Dr. Ashok, sir, what are the treatment options? We have discussed that, and how long to treat? What is the natural course, and what is the long-term prognosis of cutaneous PAN?
Well, I alluded to this answer to this question earlier. Now, as you said, she has already tried methotrexate and high-dose steroid. As I said earlier, I would try azathioprine, mycophenolate mofetil, but also, as you know, these days we have the jack of all trades. So that will be a nice thing to try, because I have seen this molecule working in non-healing ulcers. So yes, I would say that should also be considered in the therapeutic armamentarium as of today. And for this might prove quite remission inducing in a patient like this. Of course, the problem of relapses is likely, and one would have to give multiple courses of whatever agent you choose. And long-term prognosis is generally of this kind.
Yeah,
you keep on having relapses.
So with this, we start our third case, young male, 21-year-old male. Again, he presented with short history of 3 months duration, fever, weight loss of 6 kg, myalgias and polyarthralgias for 3 months, pain in both feet while walking, burning pain in both the forefeet, continuous burning pain, coldness of feet, inability to walk, and finally gangrene toes and left forefoot. Progress to gangrene left foot and right first, third, fourth toes had tip blueness. This was the picture. Examination showed hypertension. BP was 150 by 100. Both feet were cold, pale, and had absent pulses. Bilateral posterior tibial and dorsalis pedis. Toe gangrene. High acute phase reactants. And urine showed protein of 800 milligram per deciliter. Serum creatinine 1.96. Echo was normal. Chest X-ray normal. Viral markers negative. ANA, ANCA, APLA negative. Doppler ultrasound lower limb, complete occlusion of anterior tibial, posterior tibial, and peroneal artery, both lower limbs. And DSA renal vessels showed multiple microaneurysms. So to summarize this patient, young male presented with short history of fever, weight loss, myalgias, arthralgias, hypertension, and gangrene, with raised acute phase reactants, absent tibial and peroneal pulses, microaneurysms on renal angio. So what are the conditions that can cause gangrene? Dr. Mishra sir.
This is an unusual case. The presence of claudication pain and gangrene over the distal extremities, particularly leg, and the presence of microaneurysms with systemic features are, I was a little baffled, but the giveaway is the presence of microaneurysms and the gangrene and the presence of systemic features. Of course, we would keep in polyarteritis nodosa or medium-sized vessel involvement. What is little odd is the long segment of the artery being involved. The lower limb vessels, as you said, the Doppler studies reveal that total occlusion of the anterior tibial artery and the peroneal artery.
Yeah.
That is, the longitudinal involvement, but he's a young man, a 21-year male, so atherosclerotic disease is unlikely at this age. My thoughts are a little blocked actually. I have not seen so extensive longitudinal involvement of the artery in a classic polyarteritis nodosa. The microaneurysms that are present in the renal vasculature, they do suggest classic polyarteritis nodosa. And of course, the fever, weight loss, the presence of systemic features, and quite extensive gangrene actually. This gangrene indicates that his vascular supply in the leg is quite compromised.
Dr. Ashok sir?
Well, I agree that this long segment occlusion of tibial arteries and peroneal is unusual, but the diagnosis remains classical PAN. You may call it atypical presentation, but I don't think any other disease fits into this. However, microaneurysms can be caused by other vasculitides as well. For example, GPA, Church-Strauss aneurysms are known. Even in vasculitis caused by SLE or rheumatoid, they have been described. So microaneurysms are not something absolutely unique to PAN. But in this setting, I think they definitely go in favor of the diagnosis of PAN only. And in general, if you say what are the causes of gangrene, there are so many other conditions that can cause gangrene, but they will not be relevant here.
Yeah, I am talking about this patient.
This patient, asymmetrical gangrene is very much
unlikely
underlying vasculitic disease only. So we have to confine our discussion to Antiphospholipid syndrome can be considered, but then you don't get microaneurysms there.
Is it possible to have pain with secondary APLA?
Well, it is known. It is known. Either way, APLA can have vasculitis and vasculitis can have secondary APLA.
So, Dr. Mishra, sir, can you explain this by associated some thrombotic condition?
Yes, it's a very rare association of PAN with other bland vasculopathic like antiphospholipid syndrome, or those that are associated with basic defect of the vessel like Marfan. But the presence of these microaneurysm and the relatively recent onset, one need to look out for antiphospholipid antibodies and other factors that causes a procoagulant condition.
Yeah.
But to me, I don't think that's very much a possibility, though we need to rule out. I'm a little bit biased with the presence of these microaneurysms, though
Okay.
Professor Ashok said that there are other conditions which can cause it. But the presence of this with the systemic features and the gangrene. But here something is bothering me, that the long
Segment.
extent of longitudinally, so much of vessel block. I have not seen a case of a classic polyarteritis nodosa. This is very, very, very odd.
Yeah. So the next question is it possible to have this extent of gangrene in a small vessel vasculitis? Dr. Ashok, sir?
I would say practically very, very rare to have this extent of gangrene with a small vessel vasculitis. Rare instances are known, like, in meningococcal, meningococcemia, you get purpura initially, and then it becomes purpura fulminans, and then final picture may look like this, extensive gangrene. They all coalesce. But then that kind of progression, one understands, when one is observing the patient, and gradually that sort of thing develops. But de novo, such extensive gangrene to develop in a small vessel vasculitis would be very, very unlikely.
Dr. Mishra, sir, can we get this kind of gangrene in large vessel vasculitis?
Yes. Large vessel vasculitis, Takayasu arthritis or giant cell arthritis can have rare association of gangrene. So we have seen case reports of digital gangrene with large vessel disease. But again, the presence of these microaneurysms will be very odd to explain that. Large vessel vasculitis, there are conditions which they are called variable vessel vasculitis. Means large vessel can be involved, medium-sized vessel can be involved, and small vessel can be involved. We don't have evidence of small vessel disease. We have got medium-sized vessels, and we don't know. We don't have the proximal arteriographic studies. Basets is one condition which can cause variable vessel disease. But I would, those are theoretical discussion, I think. It is possible.
Okay.
It is possible.
Sir, Dr. Ashok, sir, what are the causes of symmetrical peripheral gangrene?
These are, general medical conditions like septicemia with DIC, or, you have given some norepinephrine drip and it has, had severe effects, and peripheral symmetrical gangrene can occur. Catastrophic antiphospholipid syndrome can have symmetrical gangrene. So those are rarities.
Okay.
Yeah.
Sir, Dr. Mishra, sir, how common is hypertension in polyarteritis nodosa?
Hypertension is fairly common. I can't tell percentage wise, but hypertension particularly a recent young onset hypertension, is one of the factors that was initially described in the 1990 classification criteria for polyarteritis nodosa by the ACR. Though those criteria are not exactly used for diagnosis, hypertension is definitely an important clinical feature for consideration of diagnosis. Common, it may be 30-40% or more. I can't.
What
You
is the
know
common
what?
thing?
These classic polyarteritis nodosa series have come down with the description of microscopic polyangiitis. However, this disease, the largest series I remember is that of a 124 patient. And with the advent of this microscopic polyangiitis, many of the classic polyarteritis nodosa diagnoses have become less common. But let's say 40 to 50%.
Yeah. Sir, Dr. Ashok, sir, how to manage these patients? Like this patient, how to manage?
Yeah, management is a real challenge. See, I have recently faced a similar case, not exactly a case of PAN, but a lady with scleroderma who kept on progressing with gangrene. And we tried everything. What we usually try is high dose steroids, steroid pulses, plasma exchanges, IVIG, rituximab, all those things. And just hope for the best that the gangrene will stop somewhere and it will not progress. But if it decides to progress, we really don't have much beyond these agents. And ultimately, you wait for the line of demarcation to appear and do an amputation. Because pain is also a very severe symptom. When there is ongoing ischemia, the biggest problem becomes to control pain. You may be doing nerve blocks, you may be giving severe opioid analgesic high doses and all that, but many times nothing seems to work, and ultimately it is amputation that leads to patient's relief. However, in this setting, you are basically first interested in controlling the progression of disease, and so you will do all those things. Steroid pulses, IVIG or plasma exchange, cyclophosphamide, in the hope that ultimately it will control. Immediately it is not going to do anything great. So that's about it.
Sir, if you say, can we take some questions from audience also just now?
Yes, sure.
Sir, Dr. Malviya sir has written, I have seen such gangrene with APS where microaneurysms give away the diagnosis. Sapan polyangiitis overlap. This term is no longer used, I guess. And for single organ PAN, as it's discussed, it's a histopathological diagnosis, and this is a comment. And again, no oral genital ulcers. Can it be some variant of Behçet's? Dr. Mishra sir has already told. And role of rituximab in management of systemic PAN. Dr. Ashok sir has told that there is no.
It can be experimentally. I mean, one can try everything, and there are case reports of success of rituximab in polyarteritis nodosa. There are case reports.
And one question from Professor Renu Sehgal. Proteinuria usually is not present in PAN, but I think because of hypertension, sometimes we can have proteinuria. And
small amount of proteinuria is possible.
Possible, yeah. And the next question is, any role of blood thinners, Dr. Mishra sir?
No.
Okay. The next case is 28-year-old male presented with 6 months history of abdominal pain, loss of appetite, vomitings, testicular pain, low-grade fever, malignant hypertension, 2 episodes of GTCS. Examination showed BP of 180 by 110, high acute phase reactants, ESR 65, CRP 153, hemoglobin 8.8, neutrophilic leukocytosis, thrombocytosis, AST, ALT both were raised slightly, 66 and 54. Hepatitis B surface antigen was positive, HBV DNA positive, HBe antigen negative, serum creatinine 2 milligram, urine albumin 2 plus, hematuria positive, chest X-ray PVU normal, ultrasound abdomen normal, echo normal, CT head and MRI brain diffuse white matter lesions, blood culture, urine culture normal, ANA ANCA normal. Renal angiogram showed bilateral renal artery aneurysm and left renal artery stenosis. So, if we summarize this patient, 28-year-old male, presented with abdominal pain, testicular pain, fever for 6 months. Recent onset malignant hypertension, high acute phase reactants, deranged renal function, HBsAg and HBV DNA positive, and microaneurysms of renal vessels with left renal artery stenosis. So the first question is, what are the renal and GI features of polyarteritis nodosa? Dr. Mishra, sir.
I had in a case discussion earlier told that the renal manifestations of polyarteritis nodosa as opposed to small vessel vasculitis is that we don't see glomerular inflammation here in classic polyarteritis nodosa. That means you would not expect RBC cast here. Hematuria can be there because of aneurysmal rupture, and the renal manifestation of polyarteritis nodosa can be hypertension, proteinuria, as was just mentioned, but not RBC cast. The GI features of PAN, the classic GI features, they're actually very common. About 40 to 50% of patients do have abdominal pain. And since the pain is precipitated by food, it's called as intestinal angina. And one can get even melena. So abdominal pain is a very disturbing manifestation of classic PAN.
Dr. Ashok, sir, what are the other clinical mimickers in this patient?
Well, before that, I would just like to say that it is not just melena, because it's an arterial bleed, it can be a massive bleed. Patients can just go into hypotension and collapse. So catastrophic bleed from per rectum is, you can say, a very typical feature of abdominal involvement or GI involvement of PAN, and one should be prepared for it. If already there is a suspicion, you have to be ready with blood transfusions and other resuscitative measures, and urgent surgery may be required, laparotomy may be required, and surgeon may have to go in at very odd hours to fix the problem, otherwise the patient may be lost. Other clinical mimickers to such a dramatic syndrome, I'm not aware. You have put this question, but if I see this story,
yeah, there's no other
playing out in front of me, I would hardly consider any other, because so many things are happening.
Yeah.
One thing you have mentioned is deranged renal functions. Now, deranged renal function may occur because of malignant hypertension. Because renovascular hypertension can be very severe, and these patients develop renovascular hypertension, and that can be very difficult to manage also. So, as a result of that, seizures may happen, and kidney function may get impaired. Otherwise, polyarteritis nodosa as such may not impair the renal function. It may simply, lead to hypertension.
Yes, sir. I think arcuate arteritis and glomerularitis are common in PAN. Glomerulonephritis is not, we don't see. Yeah. And because of renal hypertension, sometimes we can get renal infarct also.
Yes, sure.
The second question is, what are the imaging features of medium vessel vasculitis? Dr. Mishra, sir.
The imaging features of medium vessel vasculitis, the characteristic features are microaneurysm that we have seen in couple of cases, and usually they are restricted to the abdominal vasculature, the renal or mesenteric vasculature. I must submit the many cases where we had done with features classical of polyarteritis nodosa. I mean, you would have many features of classic polyarteritis nodosa. Arteriographic studies have not been positive. Microaneurysms were not seen, or the pickup, I don't think is very high, at least in those cases that we have had come across. But the classic features are small aneurysm and obstruction of the vessels. The aneurysms are a subsequent pathology. First, the vessel would get occluded, and then because of the internal elastic laminar disintegration, you get microaneurysms.
And what are the common sites of aneurysm, sir?
The renal vasculature, the mesenteric, and in the celiac axis. And as you have demonstrated here in the previous case, it's usually the vessels that supply the kidney and the intestine, the superior mesenteric, the inferior mesenteric artery. Those are the vessels. You don't tend to get the vessels. We usually do selective arteriographic studies of the renal artery or the mesenteric artery in the celiac axis to find the microaneurysms.
Yes, sir. Ashok, sir, would you like to add something?
I think there are not many other things. You'll get segmental stenosis of the arteries. Sometimes the irregularity of the arterial wall, those might be picked up. These kind of things are noted more in CNS vasculitis, where it is the imaging which gives you the diagnosis rather than anything else. Hardly any patient goes for brain biopsy. So the vasculitis limited to CNS, medium vessel, medium-sized arteries may show crooked kind of walls and sometimes aneurysmal formation. That gives the clue.
Yeah. And Dr. Ashok, sir, how common is HBsAg positivity in polyarteritis nodosa?
Well, it is said to be about 30 to 35%. But these days, as has been mentioned earlier, that microscopic pan mixture has been segregated, and now classical pan as such has become even a greater rarity. What exactly is the current HBs antigen positivity rate? I'm not sure, but it may be still to the same tune.
1/3 of the patients.
1/3, yeah.
Dr. Mishra, sir, other diagnostic possibilities with microaneurysm on renal angiogram?
Ask the question to Ashok, because Ashok answered that question earlier.
Yeah, Dr. Ashok, sir.
I think it is a repetition. We can go ahead.
Yeah. Any difference between hepatitis B positive and negative pan in presentation, treatment, and outcomes, sir? Ashok, sir.
I think the presentation is similar, except that in some cases you might be aware that the patient is hepatitis B positive, and it is said that the polyarteritis nodosa develops in the initial 4 months of infection, and features start appearing. Otherwise, the clinical picture may look very, very similar. The other thing that is said is that GI involvement tends to be more severe in patients with hepatitis B associated polyarteritis nodosa. The problem is actually in the challenge of management, because often these patients will be having active hepatitis B going on, and now you are required to immunosuppress them because they have developed severe manifestations. And so your difficulties arise from that. In such a patient, you will think 10 times before going ahead with cyclophosphamide or steroid pulses. So what you actually do is combine antiviral therapy with tenofovir or entecavir or whatever our gastroenterology colleagues advise for control of this disease, along with steroid. 0.6 milligram per kg would be my choice, and observe in the next 1 month or so or 2 months how the patient is doing. However, you may choose to add plasmapheresis or IVIG along with this, because this will be safe to do. But if in the next 1 to 2 months patient is not improving, not stabilizing, then after achieving some control of hepatitis B infection, you would go ahead with even cyclophosphamide. And this I have done in a patient, and patient did ultimately do well, but there were problems, of course, because of comorbidities. He had reactivation of tuberculosis, he had some other problems in the abdomen, had to be operated, and then the wound had to be kept open. The healing had to be by secondary intention and all those things. So those were other challenges, but the point is that the treatment principles still remain the same, except that you have to add antiviral and try to control hepatitis B and hope for the best. The best part is that if hepatitis B gets controlled or cured, that means seroconversion takes place, then the disease is gone forever, because this is not going to relapse.
And sir, how long to give this antiviral treatment?
Antiviral treatment is guided by our gastroenterology colleagues. I mean, it goes on until HBV DNA becomes negative and remains negative for a few months at least. So this is something you have to do in collaboration with the gastroenterologist.
Dr. Mishra, sir, would you like to add?
Well, generally, these patient treatment is complicated. You have to first give antiviral treatment with steroid, and basically the disease treatment becomes a protracted affair. And I have seen patients who continues to have replicative virus in the blood, and that makes treatment a challenge. To give cyclophosphamide is a little challenging. We know that cyclophosphamide is the main inducing drug for classic polyarteritis nodosa. And the fact that you have to give somewhere between, at the end of 2 months or 3 months of antiviral treatment, one cannot recommend giving antiviral with cyclophosphamide and prednisolone. Yes, as Professor Ashok said, steroid at whatever comfortable dose, 0.5, 0.6, or even 0.75 milligram with antivirus, antiviral agents, and then wait for the virus to not to be replicating, give cyclophosphamide. And the good thing is that in general, the treatment is longer as compared to those which are HBsAg negative. And one tends to believe that it is the HBsAg that triggers on the vasculitic process. So if we get fairly consistent HBsAg negative or eDNA negative, then the clinical course becomes, the patient is remitted. But it is a challenge.
Yeah. Thank you, sir. With this, we have finished all 4 cases. We have few questions from audience. I think we can take them. We have discussed role of rituximab in management of systemic pain. Then Can cryoglobulinic vasculitis cause symmetrical peripheral gangrene?
Yes, it can. It can.
And some of our colleagues use anticoagulants in these, even direct oral anticoagulants, if not heparin. Is there any evidence for same, sir? Dr. Mishra?
I'm not aware.
Dr. Ashok, sir?
I don't think it will work. It is given in the apprehension that the thrombosis is progressing, but then it is progressing because of underlying inflammation, and anticoagulant doesn't stop it. It fails.
And then Dr. Malviya sir has written that L-prostadil infusion can help.
L-prostadil.
L-prostadil.
Yeah. Well, it's a good vasodilator. I mean, it improves the capillary circulation, small vessel circulation. It may have a role.
Yeah. Then Aman has given that we have seen recently this kind of gangrene in GPA in post-COVID era.
Which kind of gangrene? The leg gangrene?
Yeah, that forefeet and other toes gangrene with long segment involvement.
So
this was very odd. This was very odd.
That's a tribute to Corona rather than GPA.
Sir, Dr. Mishra sir, for you, how to differentiate segmental arterial mediolysis from polyarteritis nodosa?
Where is this question?
Sumit has asked. अमन के बाद में पूछा उसने सुमित.
I don't know.
Segmental medial arteriolysis.
Segmental arterial mediolysis.
Where do you get this? It's a radiographic term.
Yeah, I think this is rare connective tissue disease जो होता है उसमें.
Oh, some.
No, I'm afraid I
connective
can't.
Tissue disorder.
I can't.
Non-inflammatory, isn't it? It's a non-inflammatory condition.
Yeah, it is a non-inflammatory condition, but sometimes present with microaneurysms and this kind of.
Yeah, but they will not have any signs of systemic
But
disease.
will they have systemic features?
They will not have.
Then the next question, next question from Aman. Another comment is that the weakness in mononeuritis multiplex does improve the improvement, but it does improve. The improvement is slow, may continue to improve up to 9 to 12 months. He may be right, but sir, I have seen patients of axonal neuropathy not improving even after 4 years or 5 years.
Yeah, it is. I would agree, but generally we don't see patient respond despite all form of therapy and of course physiotherapy. If there is foot drop and wrist drop, it's very, very difficult to come back. They get some improvement, but it's best not to predict the patient or say reassure the patient that things will be all right.
Yeah. Dr. Ashok sir, this question from Harsh Jain. Can medium vessel vasculitis present with acute arterial thrombosis?
Acute arterial thrombosis. It can certainly present. I mean, like it can present with occlusion purely because of stenosis. There may also be possibility of thrombosis on top of inflamed intima. There can be.
Yeah. Then another comment from Aman Sharma. The imaging changes seen in 60 to 70% are vascular changes. They are microaneurysms, stenosis, and organ changes like splenic original infarct, as we have discussed.
Yes.
Then Dr. Sahana from Mangalore. How often do we see aneurysm on angiography? Some cases where biopsy is not possible, can we still diagnose it as polyarteritis nodosa on basis of aneurysms?
Yes, we do that all the time.
But I think that aneurysms are seen in around 40 to 50% of the patient.
Yes.
60%.
The sensitivity is 40 to 50%.
Then next question is in positive cases, what do you prefer? Start first immunosuppression or antiviral? Dr. Ashok sir, this is hepatitis B positive.
I already mentioned, we start with antiviral plus a certain dose of steroid. and we can add plasma exchange, plasmapheresis to this regimen itself.
Yeah.
So this is the starting protocol.
Then Aman has given one reference, that is Clinical Radiology 2016 March 71 issue, and another is 2015, Role of Multi-Detector Abdominal CT in the Evaluation of Abdominality in Polyarteritis Nodosa. Then next question is from Professor Renu Saigal, antiviral lifelong?
No,
No.
not required lifelong.
I think some of the experts say that we can stop antivirals after stopping 6 months of immunosuppression.
Yeah, once immunosuppression is stopped, no need for continuing antiviral.
Yeah.
Hepatitis B can get cured.
Yeah. The next question is from Prakashini. Even after the end of 2 to 3 months of antiviral, if it is still actively replicating disease and systemic vasculitis features, gangrene are progressing, do we prefer cyclophosphamide or try IVIG?
IVIG, if the patient can afford, would have been tried even before that. But in a desperate situation, cyclophosphamide has been given. It is published in literature, and I have personally witnessed it working. So all that is possible. It is a hazardous approach, but then if you are desperate, you do everything.
Then next question is from Dr. Prashant Stotelia. Once involved organ being removed surgically, still systemic therapy is needed for single organ pan? Dr. Mishra?
No. In the first place, pan was not suspected, and after removing the organ, if there are no features if there are systemic features, no treatment is warranted. This is a single organ limited disease.
Yeah. And then regarding anticoagulants, Aman has commented that anticoagulation may lead to hemorrhage.
Yeah. So
we don't recommend anticoagulation in classic polyarteritis nodosa cases. Even that case where there was extensive gangrene, I would be very hesitant to recommend anticoagulation.
Then next question from Sapan. Do you think more and more of whole exome genome sequencing, especially in younger patients with these syndromes, will bring new constructs? Any data already except data 2 for the increased importance of studying somatic mutations? Dr. Mishra, sir.
I really don't know the answer. If you probe the gene, you explore the gene, you'll find some mutations. But is it worth? I really don't know. I would strongly dissuade to do very extensive investigation. I know that whole exome sequencing is now available. Well, I would leave it to the individual rheumatologist to take that call.
Dr. Ashok, sir, any comment?
I agree. I mean, we should not overuse this new investigation modality. Already, Dr. Aman Sharma has mentioned that the lab is flooded. So, indiscriminate requests coming from all over the country will basically lead to this kind of.
Then next question is from Dr. Prakashini from Bhubaneswar. Should Behçets not be considered as there were microaneurysms in third case? Yes, we have discussed that. The differential diagnosis of Behçets, but no other features suggestive of Behçets. Then how many doses of cyclo would you like to give in systemic cancer? Dr. Mishra.
I told 6.
Yeah.
3 2 weekly, 3 weekly.
Yeah. After that, you shift on either Azoran.
Then you move on to Azoran and or methotrexate. But Azoran, in PAN cases, Azoran is the preferred step-down drug.
Dr. Malviya sir has written that Professor Mishra gave the doses for cyclophosphamide schedule for PAN. There are several different cyclophosphamide schedules for different immunological diseases. Can either of the speakers provide the different cyclophosphamide regimens for different diseases?
गुरुजी को क्या आंसर करे? Yes, sir. For lupus nephritis, for example, wherein mycophenolate is strongly taking the place of cyclophosphamide, for the urolupus, we give 15 milligram every fortnightly for 6. We don't space it as we space it out for the vasculitis, ANCA-associated vasculitis or PAN. If we prefer to give the NIH protocol of cyclophosphamide for lupus nephritis, then of course the dose is higher. It's 750 milligram per square meter of body surface, pulsing every month for 6, or may extend to 9 if at the end of 6 months there is still continues to be proteinuria or disease activity. So basically for PAN and ANCA-associated vasculitis, it is the UVAS protocol. That is 15 milligram, 2 weekly for first 3 and then 3 weekly. For urolupus, it is 2 weekly for 6. And for the NIH, it is monthly, a little larger dose of cyclophosphamide. Is that, sir, what would you want, or?
And Madam Renu Sehgal has commented that relapse rate is very high in hepatitis B. So gastro people say in majority we give lifelong antiviral. Maybe true. Yeah. Then next question, very interesting, from Dr. Sahana, Mangalore. Sir, if there are no aneurysms or stenosis and biopsy is not possible, and patient has features of medial vessel vasculitis like ANCA, MPO, PR3 negative, CNS myocardial involvement, after ruling out infection in a young patient, can this be diagnosed as a probable PAN? I think yes.
This is a more real world experience. In real world experience, you suspect classic PAN, but in reality, you do the arteriographic studies, they are negative, and biopsy, if for any reason, Professor Ashok Kumar said that if the patient has sensory features of sural nerve involvement, you do a biopsy, and the person is good enough to pinch the sural nerve, then it's fine. Otherwise, we have seen many cases where the biopsy has been done, yet the results are either the nerve is not there. So we will go by the clinical picture, the presence of systemic features and the organ manifestation that we described, and we call it probable PAN. There is no harm.
Even if there is no pointer, blind biopsy has a 30% chance of giving the diagnosis. Say muscle biopsy, testicular biopsy, sural nerve biopsy. Even if there are no direct clues, there is a 30% chance. But if you don't get anything, you can very well go with empirical approach.
Sir, Dr. Amin sir has written that I have not seen a new PAN in past 10 years. Has the incidence decreased?
Incidence has definitely decreased, but
incidence has decreased, and many cases of PAN have now been called as microscopic polyarteritis. So I don't think the incidence has fallen, but yes, they have been labeled alternatively.
Yeah. And the last question is from again Dr. Sahana, Mangalore, same patient. How long do we continue maintenance immunosuppression in polyarteritis nodosa? Any tapering regime suggested? I think we have discussed that.
18 months.
18 months. And Dr. Aman has conveyed thanks from their behalf also. So with this, I think we conclude this session. I thank Professor Ashok Kumar sir, Professor Mishra sir, and all the audience for attending this meeting on Sunday forenoon. And thank you everyone for this meeting. Thanks.
Thank you.
Actually,
Thanks.
I learned more than what I planned to say.
Same here.
So, information, and Aman said something, giving a reference. It was very enjoyable.
Great session.